Hello, everyone. This is Ryan O'Malley. Topic today is peritoneum and mesentery. This will be a case-based review going through a variety of different entities that involve the peritoneum, retroperitoneum, and mesentery. This is sort of a wide variety of different things, some of which are specific or unique to the location that they arise from, and others that are systemic or multi-system entities that involve any or all of these structures. So we'll go through them, starting with the peritoneum and then, excuse me, starting with the mesentery and then ending with the peritoneum. So the objectives for today are to use a selection of cases to demonstrate the sort of broad variety of pathology that can occur in these locations. The key point from today is that many of these have overlapping imaging findings and rarely have a specific imaging appearance and with a single diagnosis. Most of the time we have to give a differential here, and the crux of the talk will be how you can use the clinical information and some of the imaging features to help narrow your differential and suggest maybe a few diagnoses rather than a broad differential. Um, we will go through a few entities that have specific presentations or specific imaging findings. And so when you see these cases, you can be more specific with your diagnosis. Um, but most of the cases will require you to gather some additional clinical information, either how the patient presents, whether they have a known malignancy, and whether they have lesions elsewhere in the body to help you craft your differential. So the format for today, I'll present the imaging findings, and then there will be a multiple choice question on the screen with the images. So when you're watching this, you can pause for a second at this point to look at the images and try to make the findings yourself, and then try to answer the question. And so I'll pause briefly, but you can pause while you're watching, and then I'll go through the imaging findings and everything else after the initial slide. So here's the first question: a 65-year-old female with right lower extremity melanoma. So the findings in this case are ill-defined mesenteric fat staining following the root of the jejunal mesentery surrounding a few non-enlarged mesenteric lymph nodes. You'll note with the orange arrows that there's a preserved fat halo around the mesenteric vasculature, and there's a tumoral pseudocapsule, which is this sort of well-demarcated differentiation between the affected mesentery and the unaffected mesentery, where you imagine that you could draw a line uh, delineating where the fat stranding is and where it's not. So the question here, what's the most likely diagnosis? This is mesenteric paniculitis. Mesenteric paniculitis is in this category of kind of benign idiopathic inflammatory processes, in this case specifically involving the mesenteric fat. These are commonly detected incidentally in patients who are imaged for other reasons. You probably see these more than once per day on any abdominal imaging service. The key takeaway here is that the vast majority of these do not progress or evolve into malignancy. And in fact, I should say, not the vast majority, none of these progress or evolve into malignancy when they are a primary process involving the mesentery. Mesenteric paniculitis is now believed to be a subtype of sclerosing mesenteritis, which is a spectrum of imaging findings and histologic findings based on the predominant process and underlying tissue type. So the spectrum on one side of the spectrum is mesenteric paniculitis, which is predominantly an inflammatory response where you just see this ill-defined inflammation without any discrete soft tissue or mass. On the other end of the spectrum is retractile mesenteritis, where you see this fibrotic soft tissue mass with retraction and distortion of the mesenteric structures. And the middle is mesenteric lipodystrophy, which is characterized predominantly by fat necrosis. That's the one that we see the least commonly on imaging. Mesenteric paniculitis is also considered to be a subtype or a component of IgG4-related sclerosing disease, which includes other kind of bizarre idiopathic inflammatory entities like retroperitoneal fibrosis, inflammatory pseudotumor, autoimmune pancreatitis, and sclerosing cholangitis. So here are the imaging findings, which we talked about at the very beginning, the so-called misty mesentery. We have ill-defined mesenteric fat stranding. This is a non-specific term that indicates or can indicate a variety of different things: fluid, fibrosis, or tumoral infiltration. In this case, we're just talking about fluid or non-organized inflammation. The fat ring sign is the preserved halo around the mesenteric vasculature that you see indicated by the arrows. And the tumoral pseudocapsule, where you have this well-defined border outlining the affected mesentery. Differential in this case can include lymphoma, edema, hemorrhage and carcinomatosis, and this is where you need some additional clinical information to help narrow the differential. So this is an example of lymphoma where it initially presents with bulky mesenteric lymphadenopathy, and then after treatment can have this more ill-defined soft tissue or fat stranding in the mesentery. So post-treatment can look identical to mesenteric panniculitis. Here's the second case, a 53-year-old female with fatigue. Question is, what's the most likely diagnosis? And the findings here are clusters of enlarged mesenteric and retroperitoneal lymph nodes with soft tissue extending along and around the mesenteric vasculature without a preserved fat halo. So what is the most likely diagnosis? This is lymphoma. Lymphoma is the most common malignancy affecting the mesentery, and it's the most common malignant retroperitoneal tumor. Mesenteric involvement is more common in non-Hodgkin's lymphoma as compared to Hodgkin's lymphoma, 50% of which 50% of the non-Hodgkin's cases will have enlarged mesenteric lymph nodes at presentation compared to only 5% for Hodgkin's disease. From an imaging standpoint, if you see enlarged lymph nodes in multiple stations, that helps suggest the diagnosis of lymphoma as opposed to a malignancy where there is an immediate draining lymph node basin affecting that site. So the findings here and in most cases of lymphoma are lymphadenopathy across a variety of different locations, and the lymph nodes can take on a variety of different sizes and morphology. In the mesentery, it's characteristically these confluent soft tissue masses that surround and encase the mesenteric vasculature, and you'll notice comparing mesenteric panniculitis on the left to the case of lymphoma on the right, there is no such fat halo like you see on the left side image. The soft tissue extends right up to and around the vasculature and classically encases but does not narrow the vessel in spite of long segment soft tissue contact. You may also see the so-called sandwich sign where you see confluent soft tissue or lymphadenopathy on both sides of mesenteric vasculature and perivascular fat. As I said before, after responding to therapy, it may look identical to mesenteric panniculitis, and you may only see soft tissue, ill-defined soft tissue in the mesentery or fat stranding. Differential includes sclerosing mesenteritis or mesenteric panniculitis. Calcifications sometimes give you a clue that what you're looking at is treated lymphoma. PTLD can have the same appearance in somebody who's had a solid organ transplant. Metastatic disease can obviously present with lymphadenopathy. Usually these are localized to a specific draining lymph node basin with the primary suggested by the location rather than diffuse multi-station lymphadenopathy. And then other kind of infectious or inflammatory causes like TB or Whipple disease can also be considered with this multiple location lymphadenopathy. Third case is a 44-year-old man with enlarging palpable right testicular mass. So the findings here are confluent retroperitoneal lymph nodes at the level of the renal veins, and the coronal and selected image of the pelvis shows no enlarged pelvic lymph nodes, and you also see part of a right testicular mass. So the multiple choice question for this is which is considered regional lymph node disease in the setting of testicular cancer, and the correct answer is periaortic lymph nodes. And this is a common question that you'll see on exams and in real life, and this is because of how the testes drain. So the metastatic disease from testicular cancer most commonly involves the para-aortic lymph node, and that's because the lymphatics follow the gonadal vessels to the level of the renal hyla, and the draining or the enlarged lymph nodes are typically ipsilateral to the primary tumor. So in this case, it was a right-sided tumor. You often will start at least initially with right-sided retroperitoneal lymph nodes, but then it can spread inferiorly or on both sides, and frequently skips the pelvic lymph node unless there's been prior inguinal or scrotal surgery, in which case the lymphatic distribution may be altered or different than the typical. So when you see isolated retroperitoneal lymph nodes in a male patient, you should always consider testicular cancer, and these patients all need a scrotal ultrasound as the initial workup. Most of these tumors are germ cell tumors, of which seminoma is the most common, followed by non-seminomatous. Those are classically have cystic or necrotic lymph node metastases. Staging is based on the maximum diameter of the involved lymph nodes with size less than 2 centimeters, between 2 and 5 centimeters, and greater than 5 centimeters, the sort of cutoffs between 2A, B, and C. So differential for retroperitoneal soft tissue masses includes a couple of the things we've talked about and then a few others. Again, just to highlight the same in the case for lymphoma, if you have retroperitoneal lymph nodes plus enlarged lymph nodes in other locations, that should suggest lymphoma, whereas if you see them isolated to a single location, think more metastatic disease from a solid tumor. Mesenchymal tumors can present with retroperitoneal soft tissue masses, and then the other non-neoplastic causes like retroperitoneal fibrosis or a retroperitoneal hematoma. So here's an example comparing the lymphoma case with the testicular cancer case. Again, this is the testicular cancer case has confluent retroperitoneal lymphadenopathy and soft tissue, whereas the case of lymphoma has mesenteric and retroperitoneal lymph nodes. So again, just to say this, uh, or to highlight this again, how you order this differential really depends on what additional clinical information you have, whether you know there's a primary and whether you find lesions elsewhere. So use whatever information you have available to help order this differential. Next case is a 60-year-old female with left flank pain. Question is, which of the following is an abdominal manifestation of IgG4-related sclerosing disease? So we'll go through the findings first. This patient had infiltrative retroperitoneal soft tissue that was encasing the aorta and IVC and pulling both vessels toward the spine. You'll also notice on the coronal images that the left ureter is deviated medially toward the spine, and there's asymmetric left renal collecting system dilation and an asymmetrically delayed left nephrogram. And on the upper right-hand image, hard to tell without scrolling through this, but there was similar soft tissue in and around the peripancreatic region. So the multiple choice question, which is a manifestation of IgG4 related sclerosing disease. I mentioned this in the first case, retroperitoneal fibrosis. The majority of cases of retroperitoneal fibrosis are idiopathic, and the exact mechanism is uncertain, but cases are increasingly recognized now as a systemic inflammatory process, and many of these are part of the IgG4 related sclerosing disease spectrum, including the other fibroinflammatory conditions like mesenteric panniculitis. The exact mechanism is unknown, but there is suggestion or has been suggestion that this reflects an immune response in some patients from leaking antigens from an atheromatous plaque within the aorta. So you often see this in and around either an ectatic or aneurysmal abdominal aorta. Of the secondary causes, the most common known cause is from ergot derivatives. The classic is methotrexate, which is an old headache medication. Um, there are some patients who will have this as a presentation for metastatic disease where it's thought to reflect a desmoplastic reaction to underlying retroperitoneal lymph node metastases or soft tissue metastases. The imaging findings are often the same. You have infiltrative retroperitoneal soft tissue that extends along the aorta and the IVC, sometimes going into the pelvis along the common iliac arteries, but always kind of centered around the aorta and the IVC. It can also be more extensive, like in this patient where it extended upward into the peripancreatic soft tissues. It can even go as high as the mediastinum and as low as the pelvis. The classic sign that we see, in addition to the soft tissue, is that it obstructs one or both kidneys, and causes medial ureteral deviation, like you see in the illustration there in the IVP image. On MR, if we were to image these, on MR, the imaging findings reflect the degree of inflammation. So if there's acute inflammation, you'll have avid enhancement and increased signal on T2-weighted images, whereas if you're in more of a chronic or fibrotic phase, there'll be less enhancement with low signal intensity on both T2 and T1 weighted images. Differential for retroperitoneal soft tissue includes things we've already talked about: lymphoma, metastatic disease, hematoma, and I would add one more in this category that we haven't talked about yet, which is post-irradiation fibrosis. This retroperitoneal soft tissue in retroperitoneal fibrosis looks very fibrotic, in some cases inflammatory, which can have or mirror the findings of post-irradiation fibrosis. So that's a piece of history that you would need if you were to suggest that, but another thing to consider. Um, Key point here, as I mentioned, there's a subset of these patients where retroperitoneal fibrosis is coexistent with retroperitoneal malignancy, and we can't reliably distinguish between the two on imaging. The findings often overlap, and there's been a lot of studies and publications trying to distinguish between the two, and you'll see some signs that are in some cases helpful, like whether there's elevation of the aorta and IVC off of the spine. But the takeaway is that none are sufficiently sensitive or specific to reliably distinguish the two. Um, Here's an example of what is often cited, where in retroperitoneal fibrosis of the non-malignant type, you have this tethering of the aorta and the IVC toward the spine with very little space between the two. Whereas if it's malignant, you have like the testicular cancer case where the aorta and the IVC are elevated off of the spine. Obviously, this you would almost certainly know is malignant just from the look of it, but this is just a comparison between the two of what has been suggested. Again, it's not sufficiently reliable, though, to distinguish in 100% of cases. All right, the next case is a 54-year-old female with increasing abdominal girth over 1 year. Findings here, large fat attenuation and soft tissue attenuation masses extending throughout all of the retroperitoneum with substantial displacement of retroperitoneal structures. And it's hard to tell with something that is this large, but as best we can tell, it does not seem to be arising from any of the retroperitoneal structures, it seems to be displacing and causing mass effect. And there are a few coarse calcifications associated with the mass. So the question is, what's the most likely diagnosis? This is a case of a retroperitoneal liposarcoma, which is the most common primary retroperitoneal malignant tumor. I told you lymphoma is the most common malignancy overall. This is the most common primary retroperitoneal tumor. Um, Worth noting is that 80% of retroperitoneal tumors are malignant, and of the things we've talked about, liposarcoma and lymphoma, those account for the vast majority of these. The sarcomas specifically in this location, most are either liposarcoma or leiomyosarcoma. One thing that is an important thing to highlight, retroperitoneal lipomas are exceedingly uncommon, and some people believe that they do not exist. So if you see something that looks like a lipoma in the retroperitoneum, it is almost certainly a well-differentiated liposarcoma as opposed to a true lipoma. And now that's different than the soft tissues of the body wall or elsewhere where you can have lipomas, obviously. But if you see it in the retroperitoneum, your first thought should not be that it's a lipoma. Rather, it should be that it's a well-differentiated liposarcoma. These masses as a category grow very slowly, and so when we see them, they're often, like this patient, very large. So they, over time, are more likely to de-differentiate, and that's sort of the key for the natural history of these masses. The well-differentiated versions are often indolent, whereas once they start de-differentiating, then the course sort of changes. And so when you're following these with imaging, that's the the findings that we're looking for, signs that something is turning from something looking relatively innocuous to more soft tissue attenuation and more growth. The imaging findings are as shown here. Large heterogeneous mass or masses with varying components of fat attenuation, internal strands, and soft tissue. Most of these you'll see a mixture of fat and non-lipomatous components, whether it's soft tissue, fluid, or calcification. These often displace retroperitoneal structures, and that's where it becomes tricky to help or to figure out whether this is a liposarcoma versus a large fat-containing mass arising from the kidney or the adrenal gland. And so that's if you see something that looks like this or fat attenuation in the retroperitoneum, that's the first box on the checklist, is to figure out, is it coming from the kidney or the adrenal gland? And if not, then you're in this category. Lymph nodes are rare. When they start de-differentiating and become metastatic, the disease most commonly involves the lung and the liver. I've alluded to these, but these are the three subtypes of retroperitoneal liposarcoma, the well-differentiated form, which is predominantly fat and fiber soft tissue or fiber septations. If you saw this in the soft tissues of the body wall or an extremity, you might suggest that this is a lipoma, but like I said, in the retroperitoneum, this is almost always or potentially always a well-differentiated liposarcoma. The myxoid subtype has low attenuation on CT with increased signal on T2-weighted images if you do an MR. And the dedifferentiated subtype is the one I showed you here, where you have discrete enhancing soft tissue, and that's the hallmark of dedifferentiation. So our differential here for a fat and soft tissue containing mass in the retroperitoneum, AML, like I said, if the first uh, the first question for a large fat-containing mass in the retroperitoneum is it arising from the kidney or the adrenal? If it's arising from the kidney, then it's almost certainly an AML. If it's arising from the adrenal, then it's most likely a myelolipoma, although you can have extraadrenal myelolipomas that can mimic sarcoma, like the example I've shown here. And you can also have a hematoma where you have not fat in a lesion necessarily, but you have a large hematoma of mixed attenuation, and it sort of encompasses or displaces fat, mimicking a fat-containing lesion. For liposarc, management is usually surgical, but these are difficult surgeries, as you can imagine, because they're huge masses with margins that are very difficult to achieve, negative margins. And so they often recur. And so after they've been resected and we're following them, we are usually looking for recurrence. It often recurs in the same location as it presented initially, but when it recurs, it's usually the dedifferentiated version. So what we see is soft tissue rather than fat. And so you see a case like this where it's just a non-specific soft tissue mass, but this was a patient who had had a retroperitoneal liposarcoma that had been resected. And so the recurrence just comes back as the dedifferentiated version or an enhancing soft tissue mass as compared to the fat-containing component. So our next case is a 60-year-old man with weight loss and facial flushing. Here you have a CT and an octrio scan side by side. Findings here is a spiculated mesenteric mass in the right lower quadrant with associated encasement of the mesenteric vasculature and tethering of the adjacent small bowel loops. And on the octrio scan, you also see that there is uptake in the mesenteric mass as well as a couple of liver lesions. So the multiple choice question is, in what percentage of patients does carcinoid syndrome occur? The answer is less than 10%, a minority of patients. Carcinoid tumors are neuroendocrine tumors that arise from the endocrine system outside of the pancreas and thyroid gland. It's the most common malignant neoplasm of the small bowel, classically arising in the distal ileum. And one thing that I think we sometimes forget is that the primary tumor is actually very small. It's usually a little submucosal mass that we either rarely or never see on imaging. And so what we see is the associated desmoplastic reaction or the regional spread to the mesentery. And that's usually either the first or only imaging manifestation, unless there's also hepatic metastatic disease. So the classic findings are an enhancing spiculated mass in the mesentery, which results in tethering of the adjacent vasculature and bowel. And as I said, this is are thought to be a result of the extramural tumor spread and a resulting desmoplastic reaction. As the tumors grow larger, metastatic disease becomes more common, often to regional lymph nodes, the liver, and the peritoneum. Those are kind of the three main places to check. Differential for a mesenteric soft tissue mass plus or minus calcification. There are two things that we've talked about already. Retractile mesenteritis, that's the fibrotic form where you get this spiculated soft tissue mass with calcification, or treated lymphoma, which often has calcification after a favorable response to treatment. Other things that can be included include desmoid tumor, metastatic disease from a different primary tumor, and a hematoma. Carcinoid syndrome, like I said, presents in a minority of patients, less than 10%, but have a very characteristic clinical syndrome, including flushing, diarrhea, wheezing, right heart failure. Most of these patients have metastatic disease, and the syndrome is thought to be a result of the tumor byproducts, histamine and serotonin, that are released into the systemic circulation. Octrio scan can help distinguish carcinoid from other etiologies and can also be useful to help predict response to octreotide therapy. For localized non-metastatic tumors, the management is resection, whereas if there's carcinoid syndrome, they can be treated with somatostatin analogs. And for patients with hepatic metastatic disease, some will undergo hepatic resection or wedge resection or partial hepatectomy. And in patients who are not candidates for resection, some will undergo liver-directed therapy or can undergo liver-directed therapy. All right, so the next case, 7, 29-year-old female, status was total proctocolectomy with abdominal pain. The findings here are an infiltrative mesenteric mass in the right lower quadrant with tethering and spiculation of the adjacent vasculature and bowel. And the multiple choice question is, which of the following describes Gardner syndrome? So the correct answer here is D. Gardner syndrome includes colorectal polyps, skull osteomas, desmoid tumors, and epidermoid cysts. So desmoid tumors are the name desmoid is sort of a historical or colloquial name. The preferred, at least pathologic term now is aggressive or deep fibromatosis. The fibromatoses are a collection of benign but locally aggressive tumors or fibrous tumors that can be either superficial or deep. The superficial tumors are relatively small and slow growing, but you may see these in the abdominal wall or the extremities. The deeper versions of these tend to be larger and more aggressive. They grow rapidly and they can infiltrate and invade surrounding structures. So a few classic kind of presentations. Abdominal wall is classically seen in young women, either during pregnancy or within the first year postpartum, where they grow in and around the scar. You can see other intra-abdominal masses that either are associated with prior surgery or at the site of prior surgery in the mesentery, retroperitoneum, or the pelvis. There are familial types, or they can be familial or sporadic. The familial types are commonly associated with FAP, in which case it's part of Gardner syndrome, which is the answer to this question. Of the others, the vast majority, or of all the desmoid tumors, I should say, the majority develop in patients who've had a prior surgery. The imaging appearance is generally nonspecific and has a lot of overlap with the entities we've discussed already. This case, or the case that I shown on top, had a spiculated infiltrative mesenteric mass with encasement and displacement of the mesenteric structures, but they can also be more rounded soft tissue masses with attenuation similar to muscle. This is an MR image on the bottom right, which shows the typical signal intensity. Most of these, because they're fibrotic masses, they will have low signal intensity on T1. If there's myxoid tissue within it, then it will have corresponding increased signal on T2 as well. Imaging is usually used to help plan the surgical resection, where we're identifying the size and number of lesions that a patient might have and how extensive the involvement is of any critical structures like vasculature, bowel, organs, etc. Differential, similar to what we've talked about in all of the prior cases, carcinoid, tumor, sclerosing mesenteritis, metastatic disease, lymphoma, and hematoma. So the next case is a 64-year-old man with left lower extremity numbness and new hemorrhagic brain lesions. So like I said at the beginning, most of these cases have overlapping imaging findings, and so any clinical information should be used as a clue to help be more specific in your differential. So this history is concerning for metastatic disease, and so you should use that to your advantage. Findings in the images we have here. Some of these are tricky to see without being able to scroll through it, but we'll go through them. There's an annular mass in the sigmoid colon with associated eccentric wall thickening, and there are a bunch of rounded soft tissue masses throughout the mesentery, and a bunch of little tiny subcutaneous nodules that you see in the upper back on the top image. So the most likely diagnosis, all of these potentially could have the same imaging findings, but in the case of widespread disease involvement and this history, metastatic melanoma is the most likely explanation. Within the GI tract, the small bowel and the mesentery are the most common sites for melanoma to spread, although it can involve pretty much anywhere. and it usually occurs in multiples. Small bowel is more common than the colon, and it can have essentially any imaging appearance in when it involves the bowel. It can be intramural, it can be along the serosa, it can be polypoid masses, it can just be wall thickening, you can have a targetoid appearance with central necrosis or a big ulcer, or you can have the classic aneurysmal small bowel dilation. So much like melanoma, anywhere it can have a variety of different imaging appearances. When it involves the mesentery and the lymph nodes, it's usually both the mesentery and the omentum. The pattern in the mesentery and lymph nodes is similar to elsewhere. It can have a variety of different appearances. It can be lobular, um, or lobulated in enlarged lymph nodes, or they can be confluent or more infiltrative, where they have lymphoma with just about everything else that we've talked about before. One thing that is different is that they rarely result in the desmoplastic response that you see, like in carcinoid syndrome. All right, the next patient is a 47-year-old male who fell from 27 feet. So the findings for him are high attenuation fluid collection in the mesentery, which displaces the adjacent bowel loops. And within the center of the collection, the key finding is that you have this area of high attenuation that mirrors the aortic blood pool consistent with active extravasation or active bleeding. And he has a few pelvic fractures that we can see on the coronal images. So the most likely diagnosis is a mesenteric hematoma with active bleeding. Again, to keep reiterating this, the imaging findings alone, excluding the active extravasation, could have the same appearance as any of the other entities or any of the other answer choices listed here. Mesenteric hematomas or bowel and mesenteric injuries, broadly speaking, are relatively uncommon in terms of blunt trauma. CT is obviously the test of choice for the initial evaluation, during which most patients will get a pan scan. If you see a mesenteric hematoma, that should prompt you to look even more closely for an associated bowel injury. And the imaging findings for mesenteric and bowel injuries sort of run the spectrum. You can have the spectrum is from non-specific to specific, non-specific being ill-defined mesenteric fat stranding, where you have, this indicates that there is a mesenteric injury, but it's not specific for a bowel injury or active bleeding. Next, kind of bumping up a little bit more specific, is a hematoma. This obviously tells you there's a mesenteric injury, but not necessarily that there's either a bowel injury or that it needs to go to surgery. If you start to see irregularity of the mesenteric vasculature, now you're starting to think that there's an underlying vascular injury. And of course, extravasation of contrast is very specific for mesenteric injury and usually warrants a laparotomy or embolization. So now we'll just sort of pause here. This is the end of the mesenteric section of the talk and go through the differential of mesenteric soft tissue plus minus calcification. Again, many overlapping imaging findings, but just to go back through everything one more time, carcinoid tumors are usually spiculated soft tissue tumors, often with calcification, sometimes with liver or peritoneal metastatic disease. Retractile mesenteritis is the fibrotic subtype of sclerosing mesenteritis, where you have calcified spiculated soft tissue in the mesentery. Lymphoma after treatment can calcify when it changes from bulky lymphadenopathy to more ill-defined soft tissue thickening. In metastatic disease, if you see a variety of soft tissue masses or tumors involving many different locations, such as this case of melanoma. Desmoid tumors can have a variable appearance as well, can be infiltrative or spiculated soft tissue masses or well-defined rounded soft tissue masses. And hematomas, usually you will have that history. And of course, if you see active extravasation, that's consistent or the main thing to look for active bleeding. So just to reiterate one more time, the findings in all of these things have significant overlap. And if I hid the diagnosis over the top of these images or I rearranged them, I could probably convince you that one is the other if I just give you different histories. So you need to use any clinical information to help you figure out which one of these you're looking at. So now we'll move on to the peritoneum section of the talk. This was a 49-year-old dock worker with increased abdominal girth. The findings for him: diffuse infiltrative soft tissue throughout the peritoneal cavity, with some soft tissue scalping along the liver surface and a tiny amount of ascites. I think one thing that may not be obvious if you haven't seen things like this many times, but I want to try to emphasize is that all of this throughout the peritoneum and the omentum is all soft tissue. This is not ascites and this is not fluid. And without being able to put a region of interest on here, I can't prove it to you, but I would just say if you see something like this, be sure that what you're dealing with, or check whether you're dealing with fluid or soft tissue, because obviously it changes dramatically what the differential would be. And there are also no enlarged lymph nodes, another pertinent negative here. So question, what is the most likely diagnosis? This is malignant peritoneal mesothelioma, which is a very rare tumor or entity. This is a primary malignancy arising from the mesothelial cells in the serosa of the peritoneal cavity, which then spreads throughout the abdomen and pelvis. Peritoneum is the second most common site where we see mesothelioma. The pleura is obviously more common. Only about 10 to 15% of cases of mesothelioma are the peritoneal variant. Most of these have a history of asbestos exposure, like the pleural version of mesothelioma, but the link is not quite as strong. But the presentation is similar to pleural mesothelioma, where we have this long lag or latent period between when the patient was exposed to asbestos and when the tumor presents. Imaging findings are typically like this case where you have diffuse infiltrative soft tissue involving the entire peritoneum. And again, just to highlight, this is all infiltrative soft tissue as compared to ascites or malignant fluid. You often do have ascites, but it's rarely a significant amount. It's usually small volume, like in this case. Other clues that you may have that the patient has been exposed to asbestos is they may have associated pleural calcification, so look for that if you see images of the lung base or if they image the entire chest. And they rarely have distant metastatic disease. So if you see other suspicious lesions, you should start thinking that this is metastatic disease from something else. Differential, again, obviously includes carcinomatosis. Like I said, if you see disease involving other organs or other sites, start thinking that it's carcinomatosis from a different cause as opposed to peritoneal mesothelioma. So this is an example here of ovarian carcinoma where we have omental caking, ascites, and peritoneal nodules. Just to highlight, this shows the difference between how much fluid there was in this case where there's also peritoneal carcinomatosis as compared to the mesothelioma where it's almost all soft tissue. Other potential causes include TB peritonitis, where you get this high attenuation ascites, lymph node enlargement and peritoneal thickening. Lymphomatosis is possible, but you usually have enlarged lymph nodes in addition to the soft tissue throughout the peritoneum. Pseudomyxoma is another potential cause, but that's all loculated or gelatinous fluid or ascites. And then you can also get a serous carcinoma that arises primarily from the peritoneum, which is rare but possible. Management is a little bit variable depending on where the patients present. There are a few centers that do that evaluate and manage a lot of these patients. The prognosis is generally very poor, regardless. But the best chance or the best case scenario for patients is to go to one of these centers and get HIPEC. Next case is a 66-year-old woman with bloating and fatigue. Findings for her were starting in the right lower quadrant, there is a dilated tubular structure with punctate calcifications associated with it, and then diffuse or widespread mucinous ascites or mucinous implants that displace the bowel loops and scallop the liver surface. And if you believe me, there's also a cystic left ovarian lesion, which is hard to separate from the mucinous implants elsewhere without being able to scroll through this. So the question is, what's the most likely diagnosis? This was pseudomyxoma peritonei. Pseudomyxoma is a clinical entity that is characterized by accumulation of gelatinous ascites and mucinous implants in characteristic locations along the peritoneal surfaces secondary to mucinous epithelial neoplasia. The primary tumor is usually either bland or at worst a low-grade mucinous neoplasm. And the patients classically present with increased abdominal girth from this, the mucinous ascites accumulating. There's a lot of different conflicting or overlapping terms for pseudomyxoma. That's the name that I think most people are familiar with. The preferred term now, at least in the pathology literature, is DPAM or disseminated peritoneal adenomycinosis. So you may see that either in clinical notes or in a pathology note. Like I said, the primary neoplasm is usually bland or low grade, but when it obstructs the lumen, it can cause rupture with peritoneal dissemination, and that's what results in this in the pseudomyxoma appearance or the mucinous ascites accumulation. About 20% of the appendiceal tumors will result in pseudomyxoma. These often coexist with ovarian tumors, which were initially considered to be another primary in addition to the appendix. Now the pathology literature suggests that these are, if they present with ovarian tumors, those are presumed to be metastatic as opposed to another primary. So the entity pseudomyxoma peritonei or DPAM is now exclusively thought to result from a primary appendiceal mucinous neoplasm with involvement of the peritoneum and potentially the ovaries as a secondary manifestation. Rarely, they can also involve the lymph nodes or liver. So the imaging findings are this sort of characteristic accumulation of mucinous or loculated ascites, usually in typical locations that either correspond to fluid reabsorption or a dependent fluid accumulation, which I've listed here. Another finding that is a clue that this is not simple ascites is that there is actual mass effect upon the intra-abdominal structure. So that one of the classic signs is that you see displacement of the bowel loops toward the center, indicating that this fluid is more than just simple fluid and doesn't intersperse between the bowel loops. It's actually pushing and displacing the bowel loops. It also results in scalloping upon the solid organ surfaces, classically the liver and the spleen. And then again, look for the primary appendiceal neoplasm, which may have calcifications, and look for the metastatic disease involving the ovaries. Management is also not great in pseudomyxoma. It's generally palliative and intended to help manage symptoms that result from the accumulation of the mucinous implants. So you either do repeated surgical bulking or HIPEC. Again, best results are at these selected centers that have a lot of experience with this. So to conclude the peritoneal section of the talk, just go through the differential of peritoneal soft tissue and fluid and compare and contrast some of the cases that we talked about. So pseudomyxoma peritonei, accumulation of mucinous implants and mucinous ascites from a primary appendiceal tumor, which results in accumulation in characteristic location, central displacement of the bowel, and scalloping of the liver and spleen surfaces. Malignant peritoneal mesothelioma, where you have infiltrative soft tissue as compared to ascites, usually an exposure to asbestos, so look for pleural calcifications. Peritoneal carcinomatosis is often from ovarian or GI malignancies, so look for other sites of disease that would help suggest that this is metastatic disease. And then lastly, peritonitis from infectious or inflammatory causes, like this case of TB. In those cases, you would need either the presentation or exposure history to help you suggest that diagnosis. All of these, similar to the mesentery section, they have overlapping imaging findings, so you really need some history or some of the imaging clues to help narrow the differential or reorder your differential. So to summarize this talk, the etiologies or entities that involve the peritoneum, retroperitoneum, and mesentery often have overlapping imaging findings and may have a very nonspecific appearance. And so our job is to characterize all the findings, do a little bit of digging for additional clinical information, and try to use all of that to present something that is comprehensive or cohesive. And it may require just giving a differential, but we can at least order the differential in a either more narrowed or logical fashion based on what information we have. Some things are specific, like liposarcoma, where you have fat and soft tissue masses, but the majority require require a differential and use clinical information to help you get to the diagnosis. Thank you again for your attention. I hope this was useful. If you have any questions or any other thoughts about this, please feel free to email me. Thank you.